Good morning, everyone. Today we're going to push beyond the basics. This isn't just a review of orthodontics. This is about how we think as orthodontists when we plan and execute treatment. Every decision we make, every bracket placement, every millimeter of space closure, every angle of root torque has consequences not only for the bite, but for the entire face. So this session is a journey. We'll revisit foundational biomechanics. We'll analyze treatment approaches from both functional and aesthetic standpoints. We'll connect the numbers on cephalometries to faces in the clinic, and we'll use real cases to illustrate how textbook concepts play out in the chair. Foundations of orthodontic biomechanics. Let's start with biomechanics. Think of the tooth as a tree in soil. You can push the trunk, but the roots, the type of soil, and the weather all determine how it moves. Similarly, in orthodontics, forces applied to a crown are transmitted to the root, then to the periodontal ligament, and finally to the alveolar bone. Light, continuous forces posse allow bone remodeling. Heavy, intermittent forces risk hyalinization and root resorption. Example: a 12-year-old with crowding may respond beautifully to light continuous forces using 90 wires. A 25-year-old with dense bone and reduced PDL width may need much more careful force calibration. Lesson: same mechanics, different biology. Treatment goals beyond straight teeth. In the classic era, our goals were 1. Alignment. 2. Class 1 molars. 3. Overjet and overbite within range. But let me challenge you. If I finish a case with perfect occlusions, but the patient's smile arc is flat, lips are retrusive, and face looks older, is that success? Modern goals: function, stability, aesthetics, psychosocial impact. Case correlation: a teenage girl with bimaxillary protrusion. Functionally fine, occlusion acceptable, but she avoids smiling. Extraction therapy with controlled retraction improved lip position, boosted self-confidence, and completely changed her social presence. That's orthodontics as life-changing medicine. Growth versus non-growth treatment. Children give us growth as a biological lever. We can harness mandibular growth with functional appliances. We can guide maxillary expansion with rapid palatal expanders. But adults, growth is finished. Every movement is dental or surgical. Case correlation: 10-year-old boy with crossbite, RME widened his mid-palate, stable. 19-year-old with the same problem, RME failed, required CBCT surgery. This is why timing is as important as technique. Facial aesthetics and orthodontic responsibility. As orthodontists, we are guardians of faces. Vertical thirds: a long lower third may indicate vertical maxillary excess. Transverse fifths: asymmetry points us towards skeletal discrepancies. Nasolabial angle: too obtuse after incisor retraction. You flatten the profile. Analogy: think like an architect. If a building looks stable on paper but ugly in real life, would the client accept it? Of course not. Same with orthodontics. Clinical pearl. In extraction cases, always check the soft tissue response. Retracting incisors 3 mm may close spaces beautifully, but risk flattening the profile. The patient doesn't care about your class 1 molar. They care about how their face looks in selfies. Imaging and records is compass. Every great navigator needs a compass. For us, that's records. Cephalometries give us skeletal and dental angles. Panoramas give us overview of dentition. MRIs for TMJ evaluation. CBCT gives us true 3D. Essential for impacted teeth, asymmetry, airway analysis. Example: an impacted canine. Panorama says yes, it's impacted. CBCT says exactly where, whether it resorbs the lateral root, and how to approach surgically. That difference can save a tooth. Optimization: protecting what's good. One of the most important modern principles, optimization. Don't just list problems. List what's good and must be preserved. Case correlation. Patient with poor occlusion but beautiful full lips and convex profile. Extraction to fix bite. May retract lips and ruin aesthetics. Better approach, non-extraction, use expansion and interproximal reduction. Remember, fix the negatives, protect the positives. Conclusion. Let's close. Orthodontics is not just tooth movement. It's face movement, life movement, confidence movement. Your job as future orthodontists: understand biomechanics deeply. Diagnose holistically: teeth, bones, face, psyche. Use imaging wisely, not blindly. Treat the person, not just the occlusion. Always remember, numbers guide us, records direct us, but the face is the final judge. That's orthodontics at the professor level.